if we move forward, I'm just going to show a few slides about the current approaches to frontline therapy, and then we can have some discussion about what does our panel currently recommend in this frontline setting, and then take questions from our listeners today. So obviously, thanks to Rafat for this particular slide, when we're managing myeloma, we have the initial or frontline therapy that can be used in the transplant setting, or if a patient is ineligible for transplant, and then we move forward either with the transplant and maintenance, or consolidation and maintenance, and with supportive care along the way. And so the great news that all of us on this call have been involved with is the shift from a limited number of drugs that we had for so many years to all of the exciting availability of so many new options, all the way from the relapse use into the frontline setting. And if we look at the new options in the frontline setting, we obviously have the doublets such as Velcade Dex on this slide, Revlimid Dex, the triplets, Velcade Cytoxan Dex, thalidomide Dex, Revlimid Dex, and then also the option for Kyprolis, Revlimid, and Dex. The big question that we face right now is whether adding daratumumab as a fourth agent to the triplets in the frontline setting will be the way forward, and this is one of the things that has been a big question for the last year or two. So what is the best frontline therapy, and should we be looking at using a triplet but perhaps adding daratumumab to that? And that's what I ask in slide number 18. Now, at the recent American Society of Hematology meeting in December, a variety of studies were presented where daratumumab was combined basically with all the different triplets that we frequently use. The results from the Cassiopeia trial were presented, in which daratumumab was combined with Velcade, thalidomide, and Dex. This was a large randomized study, and so with the IFM presenting Philippe Moreau, and so it was really exciting to see the much deeper responses when you add daratumumab to the BTD, and you can see a significant increase in traditional response at the VGPR and CR levels, but also MRD, and they listed at the 10⁻⁵ level increased undetected MRD. And so I give this to you as an example of the benefit in the deeper responses and hopefully ongoing longer remissions and improved overall survival with a 4-drug combination versus a 3-drug. The results with daratumumab plus VRD were also presented, the Griffin study, also daratumumab with KRD were presented. And so we have a lot of data looking at this idea of combining daratumumab to give a 4-drug combination versus the traditional triplet. And so if we go to slide number 14, I guess that number is correct, where we have the algorithm for frontline therapy for a patient who is not a transplant candidate, for a patient who is perhaps frail or more elderly, Revlimid and Dex, a doublet, or VMP can be used. For a healthier non-transplant candidate, Dara can be combined with VMP, or VRD is certainly an excellent option and can be used in the form of VRD light as proposed by Paul, actually. And then we have the new exciting possibility to use daratumumab, Revlimid, and Dex based on the Maya trial data. For transplant candidates, the big question is whether we should use a triplet such as VRD or backup regimens of VTD or VCD alone, or perhaps combined with a DARA-based quadruplet. And then in the additional treatment phase, autologous stem cell transplant, and then maintenance for a standard or a higher risk patient in which lenalidomide could be combined with a proteasome inhibitor. And then thinking about what is the current role of transplant. Certainly on the European side, there is no delayed transplant outside of clinical trials. I think that there's probably an important degree of flexibility on the US side and elsewhere. And so if we can have, first of all, I'll leave this algorithm slide up here, and perhaps maybe Paul, you would like to comment first on how do you see the options for frontline therapy evolving right now?
Folks, yeah, I'm so grateful for the opportunity, Brian, to comment on this because it's such a dynamic space. I think the exciting news for patients is the 3-drug platform plus the antibodies are generating unprecedented qualities of response, and not only just depth and breadth of response, but durability, particularly with the impact of lenalidomide maintenance. And I think that has had such an extraordinarily beneficial effect broadly. And I would agree with all of the comments you made. I would simply add that we're now in a position to tailor our 3-drug platforms plus the 4th drug the best patient outcome based upon their characteristics of their disease, even considering their genetics and so forth, that can allow us to best understand what the best platform is. You make a very good point about delayed transplant. We obviously have been exploring this for some time, and just very pleased to report to you that so far on the determination trial, with now approximately 4.5, 5 years of follow-up and 70% interim analysis done, we can't call a difference yet between early versus late transplant, even for progression-free survival, let alone overall survival, where studies have shown no difference. So I think that obviously we'll have hopefully full information next year, but right now our French partners at the same time had full information and it showed a PFS difference but no OS difference. And the fundamental difference between the French study and ours was maintenance. The duration of US maintenance has been continuous and until progression, and it seems that lenalidomide maintenance has proved a true equalizer in terms of effect, at least so far. So we're very pleased to see that. It's a great outcome for all our patients, those who had the transplants early or late, and I think it echoes the point you make about choices in the US for sure.
Right, absolutely, absolutely. So Rafat, what is your perspective about a triplet versus a quadruplet? Are you seeing that we would move towards that? And then maybe comment about the current status of stem cell transplant.
Sure. Yeah, thanks for the overview of where we are today. Yeah, I think, we all know that response matter, depth of response matter. People are going to enjoy longer life without the disease when you really eradicate the disease to undetectable by sensitive assays such as the minimal residual disease measurement. So I really think it's, we made progress when we start using, Paul's, combination of Revlimid and Velcade. I think we are going to make more progress when we add the monoclonal antibody. You saw the Cassiopeia study and the Griffin studies all showing higher rate of complete remission, all showing higher rate of minimal residual disease. I think if we achieve a sustained complete remission and a sustained minimal residual disease, I think we're going to start talking about cure. So I think getting rid of myeloma is a good thing. And I'm so glad to see this day where we can use 4-drug regimen to induce such a deep response. So I'm really very excited about that. The question is, would you still need a stem cell transplant when you have such great eradication of myeloma? We don't know. I mean, and Paul, summarized his experience that he's been leading for a while. I mean, I think it's probably very important that we collect stem cells and store them early on for a rainy day. But, if we start designing trials based on the depth of response, we may be able to answer that questions. But I think we should aim early on, as obviously, with respecting the quality of life of the patients, minimizing side effects. Let's try to shoot for a complete remission in MRD negative state as early as possible. I think that's going to translate to long-term benefit. And
Absolutely.
So transplant may not be needed, but still we don't have any data to support it completely. So if you don't want to do transplant, collect stem cells and store it.
Definitely, definitely. And so from the patient perspective, Yelak, how do you view the idea of having this kind of a 4-drug combination? Obviously, more toxicity and more expense, but as Rafat emphasized, driving down towards deeper levels, MRD negativity, et cetera. What's your perspective?
Yeah, absolutely. Dr. Durie, this is a time for myeloma patients that's unprecedented, right? We get one drug approved almost every other day, and this is a good time in general. But as you all said, today, myeloma still is not curable. So which means that we need to decide based on risk stratification who benefits from a 3-drug combination versus a 4-drug combination, because I feel like we still need to pace ourselves if I'm going to stay as a patient for the next 10 years, 15 years, or 20 plus years. I think that is one area that I would like you guys to discuss a little bit more. The other one is around maintenance. I am not a fan of maintenance forever, but I think, as Dr. Paul Richardson said, maintenance seems to be a difference maker on how long patients end up being PFS or their overall survival. But I would like to see if that can be guided through some testing using the minimal residual disease testing or something like that, as opposed to all patients getting maintenance forever based on the whatever previous drug that they have received.
Yeah, very, very good point, Yelak. And I think that we do critically need those kinds of studies where we can look at achieving MRD negativity or undetected, as the new buzzword in this setting, and then decide if it's safe and appropriate to stop maintenance after a certain length of time if a patient does achieve MRD undetected. My personal perspective is that we'll need at least a couple of measurements so that we would have the concept of sustained MRD negativity, not just one reading, but 2 readings, perhaps 6 months apart as a minimum as a decision-making process. Any thoughts on that?
I would completely agree, Brian, that this MRD construct and tailoring therapy according to these outcomes is a very exciting way forward and still, in my opinion, an area of very active research. I'm not sure it's quite ready for prime time. And the reason I say that is the following. We know that MRD is variable depending on the treatment setting. For example, if you look at the MRD status of patients after CAR T therapy, it appears relatively unstable. Whereas in the context of induction remission treatment, maintenance consolidation, it's a lot more reliable in our experience. But I think that points to a key construct that MRD is a new tool, but we really need to be careful how we think of it and we go forward with it. I think there's this real entity of MRD negativity of the host, actually, which is an area of really important research, looking at the immune profiling of the patient that may be very important in terms of improving outcome. But broadly, I would absolutely agree with Yelak that it will be great to tailor therapy. And I love your point, Yelak, about a strategic view. Thank goodness these days, we are looking not at 3 to 5 year survivals as medians, but looking at 15, 20 year survivorships in our practices.
Right.
To me, is the privilege of being part of the myeloma community. It's wonderful to see. And I think we therefore have to realize the implications of what we do initially may have an impact later. And this is an area of very active research as well, Brian, because
yes.
Melphalan is a wonderful old warhorse, but it is an old warhorse. It is, just to be clear, phenylalanine mustard, and that's a soluble form of originally mustard gas. And the reality is, as a chemotherapeutic, it's very potent and it's extremely active against myeloma, but it is nonetheless genotoxic. And one of the worries we have is that, what does this genotoxicity in the long term do? If you expose your patient to cytoreductive therapy that is highly genotoxic, do you incur genetic injury both to the patient's stem cells and their myeloma that later, 5, 10, 15, 20 years later, may bite you? And that's a critical area of research. Now, that's very much an evolution, but it's a definite consideration. And I think that we've got better drugs now to get us to that point. And we've got, actually, very interestingly, just because I had the privilege of working for Tim McElwain, who was the founder of high-dose melphalan and stem cell support. And Tim said to me way back in 1990, if we can get away from high-dose melphalan, it will be a service to our patients. But having said that, the reality of newer drugs that can achieve the same thing seems to be there, including, actually, for that matter, highly targeted forms of melphalan in the sense. They're very different, actually, but they are in a stemness sense that may get us to the same goal without the same issues. So I think it's a really exciting time to have the choice of this and to be able to tailor treatment accordingly, as Yelak so nicely outlined.
Very, very good. Yeah. So we're touching on some questions that are coming from the audience. One was, could the better therapies move us away from transplant, which you've been touching on. Another one bears on substituting Ninlaro for Velcade, which I think is certainly something to consider. And I know perhaps Yelak would be a good person to comment on that.
Yeah, absolutely. So I switched from Velcade to Ninlaro when Ninlaro was first approved in November of 2015. And by January, I switched to Ninlaro and was on it for about 3 years before I discontinued that and changed it to a different therapy. But I think it is, in a maintenance setting for me, it was very effective. I tolerated it well, and I like my doctors, but I didn't have to go to the doctor's office as often, which was a blessing for me.
Yeah, very, very good. And then another question, a similar kind of question, is that with the recent approval of isatuximab, which we were pleased to see in combination with pomalidomide and dex in the relapse setting, how do we view that moving forward? The question is about in the frontline setting, and there are some studies going on now, trials with that, but right now we don't have data related to isatuximab in the frontline setting. Anyone like to talk about that as a daratumumab alternative? It was good to see the approval in the relapse setting.
Rafat, do you want to go first, and then I can comment in a moment?
You did the study, so go ahead.
Okay, no problem. It's my privilege to have been part of the Spicaria study group, and this was an international trial, and actually Dr. Michelle Attal and I were the principal investigators. It's so interesting, Brian. Isatuximab is fascinating. I think it's important to realize it is different to daratumumab. It binds to a different epitope, and it has different effects that qualitatively, preclinically, are quite striking. Whether they are translating into the clinical setting remains to be seen. But my feeling is, I'd love Rafat's thoughts on this, that, for example, in lymphoma, we use Rituxan as part of CHOP Rituxan, we use Rituxan plus ICE, Rituxan plus EPOC, as we treat our patients sequentially across the natural history of their disease. I think myeloma is a lot smarter than that. And I think that, we're going to be needing to use different CD38s at different times. So my inclination is that whereas daratumumab clearly is translating into tremendous benefit up front, it may be very important, for example, to have isatuximab in combination with other drugs that can then meet the challenge of when the disease breaks through daratumumab. And it may be an important construct to understand. Similarly, it may be worth noting that isatuximab has different side effects, and the issue there is so important because what it can do is be given to patients with chronic obstructive pulmonary disease and asthma much more safely than Dara's, in my experience, very safe, but you have to be very cautious in patients who have pulmonary disease. And I think there are aspects of that which may be also relevant as we go forward. But I'd love Rafat to comment more.
Yeah, so I'm clearly impressed by the data you presented and published on the combination of the new anti-CD38 with pomalidomide. So I think the question is, will this be a different drug that will be with different side effect profile, can be used in patient who's been exposed to daratumumab before with maintaining activity. I don't have any data. I don't have any experience yet to comment on that. It's good to have more options. I think makes it easier for us to take care of patients. I would love to have more data to help me out.
Absolutely. It just take time for that. But I think in the short term, we do have the shorter infusion time, which is helpful. And I think it will be more cost effective, I think, also. But these are things we need to see and see what will be the positioning of isatuximab moving forward.